It's our second forum, and today we are focusing on hospice care. So I'm going to give again brief introductions of our speakers who have been so generous with their time to come and be with us. On my immediate right, we have Narasat Hassan, who I've had the pleasure of working with recently on a project that she can maybe talk to you about. She's the Vice President of South Carolina Operations with the Carolina Center for Hospice and End-of-Life Care, and she has had a long career in healthcare and hospice. She started off in 1981 as an oncology nurse.
You have to tell them that day.
No. She started off like 6 years ago and it's done 20 years. She loved caring for her patients in a holistic manner and realized that hospice would be a perfect fit. So she began hospice, I'm not telling when, and she served in various roles in hospice, from nurse to administrator, hospital programs, independent community programs, as well as for-profit, not-for-profit, as well as working with folks like me on grants to improve the ability for them to provide better care. She's also served on the board of directors for the agency that she's now the vice president of. She also, this is important, I think it's important for these bios because it shows you all the possibilities that you have for working in a field as a social worker. So she's a nurse, but she works hand in hand with hospice and palliative care providers, including social workers, which you didn't put in, which I just added, regulators, payers, and other community organizations who care for patients throughout the care continuum. Because we know that we have to work together as professionals these days. No one discipline can do it alone. So that's why I wanted Narasat to be on this panel, so she could talk about her experience as a nurse working on teams with social workers. She has a lot of other stuff here. She's a trainer, et cetera, and she's a proud next graduate of the University of South Carolina School of Nursing. Yes. Okay. Now, this is a great way that we all, as social workers, we like people, we talk to people. So, to treat myself to something special on my 65th birthday, I went and had a pedicure. And I'm sitting there having a pedicure, and I'm chatting to some woman about something, and she tells me, and I tell her about this forum, and she says, "Oh, my son is in that field." So I'm sorry to embarrass you, but that's how I met Andrew. And your cousin, who works in the provost, in the office of the president, she's in charge of my endowed chair. So we have another connection as well. So anyway, Andrew is also a graduate of our MSW program. He graduated from Erskine College and with a BA in psychology. He worked for the Department of Mental Health at the Bryan Psychiatric Hospital. He worked there for a few years. That's when he got his MSW here. He took the micro path with internships with protection and advocacy for people with disabilities at the Appleseed Legal Justice Center. After that, he worked as a social worker with Agape Hospice in Horry County. Then he went to DC, worked as a social worker with adolescents. Now he's back in Columbia working as a program coordinator for the Medicaid Hospice Benefit Program. So that's another whole thing, because that's government and hospice. So you get to see, it's not just one thing. We social workers can do a lot of different stuff. And Brenda, Nicole Kavanaugh, who is right here, thank you for recommending Brenda. Brenda was originally from North Carolina, worked as a practical nurse because of her spouse's travels with the military. She started her social work education in Clarksville, Tennessee. Then the husband was transferred, so she enrolled in another program, a night program at Fort Jackson, in Hartsville, to complete her LBSW. When getting her LBSW, she had a hospice internship, and she was a perfect fit. They offered her a position, worked there until 2006. So, shows you, as we heard last week, oftentimes your internship can result in a very good job. So that's very important. She graduated from USC with her MSW, and she has now been working for 5 years at the Lighthouse Hospice. And the hospice is only social worker. She's responsible for making monthly and peer and patient visits and being the bereavement and volunteer coordinator. So you can just see from this so many different opportunities. I am going to start. We're going to, how many minutes, Rita? Did Rita disappear? Nicole, how many minutes should we give each person to kind of start with, and then we'll go on to questions?
Let's start at maybe 12.
Okay, 12 minutes, and Rita was our gatekeeper, but we're going to do it on our own. I'm here. Okay, great.
Q&A at the end.
Yes, and we really want it mostly to be Q&A. That's exactly right. Mostly Q&A. But, 10 to 12 minutes just to kind of give an overview of, it's like we're trying to encourage, we're trying to let people see all the opportunities there are in this area.
Do you need a timekeeper?
Oh, you want a timekeeper?
Sure.
Thank you. Great. Okay. What's your name?
Correct.
Corinne, you are in charge, since Rita abandoned us.
Oh.
And she came up to me with little things showing me the 20 minutes, the 10 minutes, the 5 minutes. Thank you. Thank you. Okay, Marisette, why don't you
You want me to
start?
start? Okay, good.
Thank you.
Well, first of all, thank you.
Thank you.
Sue, for allowing me to come and to share. It's good to be here. This is probably one of the things that I love most is really talking with groups, and especially have a great love for students. So through my 30-some years of
You said it, I didn't.
That's right. Very proud to be here today. When you think about the alternative, it's okay to get old, because if you're not old, you're already dead. So it's good to have some age. So I'm so glad to be here with you this afternoon. I want to sort of start with sort of talking about my whole career has been really an interdisciplinary process. So as I began my career as a cancer nurse at Palliative Baptist some years ago, already we knew that in oncology you couldn't just focus just on just the clinical things that are going on with the patient. So I found that in my practice, I really was involved in talking to patients not just about the chemotherapy they were going to receive, or the blood transfusion I was going to give, or the fact that this person's cancer had spread and how we needed to bring the family together. I really had to then connect with the other members of our team. So that meant that we were talking with the chaplain about spiritual care. We were bringing the social worker in to talk with family members about how do we do this advanced care plan? How do we look at advanced directives? Who's that person in the family that you want to designate to speak on your behalf? And so it's always been about bringing everybody together. And so as I have moved from, working on the hospital setting and then moved into hospice, it was wonderful because it felt like it was just a perfect fit. I always felt like we needed to have people working together. And so even now, years later in my role with the Hospice Association, I am working with providers. I'm working with DHHS. I'm working with Department of Health and Environmental Control with the licensing division. Once again, all of these folks who have all these disciplines and all these different departments that are working together on end-of-life issues with patients and their families. Now, I want to touch on a little bit, because we are talking about hospice, and when you talk about hospice from a Medicare definition, you're talking about the last 6 months of a patient's life if their disease runs its usual course, based on the physician's prediction about that person's illness. But I want to touch on what palliative care is, because we're getting to people who are earlier who have a chronic illness. We're finding that people are living longer, and they're living with congestive heart failure, they're living with pulmonary disease, they're living with dementia. And so they're living longer than those 6 months at the end. And so interdisciplinary care is also involved earlier. So palliative care is a focus of looking at the total person, but really allowing them to determine how they want their course to go, whether they want aggressive therapy or whether they want symptom management that sort of allows them to have the quality of life. So in the middle of that continuum, social work is involved in helping people make those decisions. So you could be in a hospital setting and working with a patient on any floor who's been referred to the palliative care service. Because now there needs to be a discussion with that family about what is your advance directive? Do you even have an advance directive? When we talk about an advance directive, we're talking about someone's decision on, number one, who do they want to speak for them regarding their health if they are no longer able to direct their care. So in my situation, when I was 29 years old, my mother died, and prior to that, she was diagnosed with cancer. So from the age of 26, 27 to 29, here I am as a nurse, fairly new in my practice, having to make decisions for my mother, who now realizes that she's not going to live past 52. She's not gonna make it. And so we're having to huddle up as a family to make those decisions. She's still getting chemo, she's getting symptoms managed, but we had the social worker, we had the chaplain, we had to have those discussions. And let me tell you, it's very helpful to have someone who's already prepared, as you are, being prepared to work with families, because if you're in the middle of that family system, you are in the middle of a very emotional time. And so it's very good to have someone who's neutral who can then convene the family and begin to talk about those situations. So I want to encourage you as you look at gerontology to see that Sue is right. We are having people who are living longer, and they are living with chronic illnesses. And so where you might not necessarily be on the hospice end, you may be working with someone in palliative care, you may be working with DHHS, with someone that's got a palliative care benefit. We've got Healthy Choice Prime that has a palliative care benefit. And so you could be a customer service case manager who's helping families to make those decisions. Now, I'm very proud to say that in my tenure, all these years, I did start up a hospice program, and I had a student who came through from the College of Social Work at Columbia College, worked with me as an intern, Emile Mitchell, and she is now the director of the hospice program at Palliative Health. But she started with me in a brand new program as an intern, and is now a regional director for Palliative Health Hospice, which has a palliative care program as well as a hospice in several counties. So there are endless possibilities of what you can do in your practice. So I'm going to pause because I'm probably close to my end.
5 minutes.
I have 5 minutes.
No, but it's okay. You can keep going. There can be so many questions. You did great.
Yeah, so I'll pause in those 5 minutes if you have questions, or we want to do questions at the end.
Let's do questions at the end.
Okay.
Is that okay, guys?
All right.
Thank you
So
so much,
I will,
Nurse.
yeah. I'll say one other thing since I got about 4 minutes. One of the things that I'm very proud that our association does is that we are really a convener for education. We really do a lot of educating all disciplines on everything related to end of life. So one of the things that you have that I put at your desk is a guide that we put together that families can use. And this is actually something that you can use as well. You're not too young to start thinking about, if I got hit by a bus and I couldn't talk, who in my family is the best person to make decisions for me? And so what this guide does is it talks about the myths related to advanced care planning that seniors sometimes don't want to talk about end-of-life discussions. It talks about some of your faith traditions. What would you want done? It gives you a glossary in the back of all the terms that are out there. So what is a healthcare power of attorney? What is a living will? What is a durable power of attorney? How does that work? What things do I need to talk with my physician about? So I want you to hold on to this and to take some time. I know you got a lot of studying stuff to do. You got a little bit of downtime, and you're not going to see the Gamecocks play football or the swim team or the soccer team or whatever. Take some time to look through this and work through it yourself. Answer the questions. Begin to think about, how do you want your life to be towards the end? What would you want done? Who in your family do you trust? It's not going to be too emotional. Who would be able to direct your wishes, what you would want done? Okay?
Thank you so much.
All right, I guess I'll go. My name is Andrew Louder, and I am the Hospice Program Coordinator for South Carolina, DHHS. To give you just kind of a little bit of background, I did graduate from the USC MSW program in 2010, and I actually took the macro track. But yeah, my internships were both with protection and advocacy for people with disabilities, and then advocacy legal justice system in my services in my second year. Before coming back to grad school, I was a human service specialist, I guess is what they call it, for Department of Mental Health at a psychiatric hospital. And what that essentially means was I was an orderly. I did direct patient care practice. I would occasionally do groups, but I took care and worked with patients directly. But in that job, I worked with social workers, coming up with care plans and things of that nature. So that was kind of my first interaction directly working with social workers. On top of that, both of my mom's parents were both social workers too, so it's, you know, yeah. So that made me want to come back to school to get my master's degree here with the program. After graduating, it was the summer of 2010, so the job market was not strong. I mean, it can be difficult to find a job with just, and I'm not trying to be discouraging, but it has the point is that I ended up working for a hospice agency, Agape Hospice in Conway. I had never actually studied hospice. So this is gonna be, I don't know if this is the best message, but the message is, keep your options open. You don't know what you know, opportunities may come up when you graduate. It may not be what you thought you were gonna do in social work, but it may end up being something that you do enjoy, and, you know, the job market being what it is, you may have to expand your what you think that you can do in social work. So that being said, I was a direct patient social worker with Agape in Conway, Myrtle Beach, Little River, that basically Horry County. That involved like service coordination with the families, working directly with the families to make sure, you know, everything's prepared for what happens at the end of life. Working directly with the patients to make sure their needs and their desires for how they want this last segment of their life to proceed. People generally don't know how to do this. This is not something that everyone really, you know, no one really thinks about. You know, no one's sitting around planning for their end of life, how they want to spend the last 6 months of their life, or what the last 6 months of their life is going to look like. So when it does happen, you need somebody like a social worker or somebody with that training to come in and, you know, help families, help the patients, especially, kind of deal with these kind of things. And sorry, I'm not the greatest public speaker, so.
No, you're great. This is great. This is exactly what we need to hear. Thank you.
Sure. I did that for 2 years, and if you're not used, it's kind of hard to talk about death, obviously, because that's what hospice is. Hospice is death. It's people dying. So it is something that you do need to be prepared for, and if you're not, it is something.
It'd be stressful.
It is a very stressful job, and it is a job that you need to have skill sets available to you, or you need to be prepared for the kind of stress that job is going to put on you, because you're dealing not only with death itself, you're dealing with very emotional families. I got cussed out plenty of times. I got the door slammed on me plenty of times. You know, later they come back and, you know, we talk about what happened. But, you know, families are going to get upset. Patients are going to get, you will have patients who are very angry at these last stages of their lives, at what's happened to them. So that is something that you're going to have to be prepared for, and something that you're going to have to deal with. After that, I moved up to Washington, D.C. and worked with adolescents. So again, I worked with teenagers with emotional disabilities who are in high school settings in the Anacostia area of Washington, D.C., if y'all are familiar with the area. So again, something completely different from what I had any experience with, but I wanted to move up to D.C. I wanted to live in D.C., and that was a job that was available for me. So I took it, and I enjoyed that job very much. Moved back to South Carolina, moved to Columbia, and took a job with SCDHHS, which kind of is me moving toward where I eventually wanted to be anyway, which was to work in government. I've always wanted to work in government. I wanted to be in a place where I could make change on the broadest scale possible. So my goal has always been to kind of progressively move up into higher levels and more policy level positions in government. As a program coordinator, basically I oversee the Medicaid hospice benefit, or Medicaid hospice waiver. It has a few different names. basically, if you are a Medicaid enrollee, you're a member, you're enrolled in Medicaid, hospice will be covered for, your hospice services can be covered by Medicaid. Sorry, I'm just trying to collect my thoughts. So when you enroll in hospice, at that point, Medicaid will pay for all services up until the age of 65, at which point you become dually eligible, and then Medicare pays for services and Medicaid just pays for room and board, which is nursing home room and board. To give you kind of an idea of this, just more broad overview of the program, currently at any one time there are roughly 3,500 to 4,000 people enrolled in the Medicaid hospice benefit in South Carolina. It roughly evens out to about 280 new beneficiaries a month, are unique beneficiaries. When you work in government, you work in bureaucracies, you always have jargon names or something. So we tend, in government. Soup. Yeah. And basically, of those 3,500, it usually, I'm trying to think of, dually eligible, okay, sorry. Those are actually all, the 3,500 are the Medicaid only. Those are just Medicaid beneficiaries. Those are persons under the age of 65. Dually eligible, I actually don't have the number for dually eligible, because another thing about working in government is stuff gets compartmentalized. Dually eligible is actually under a different budget line than mine. I have a budget line, which is the Medicaid only hospice beneficiaries. Dually eligible is actually under nursing home budget lines. To give you an idea about the budgets, my budget is roughly $14.5 million. So that's the amount of money that I oversee, and I distribute that to providers. The nursing home budget line is approximately $500 million, to give you an idea. Yeah, it's the second largest budget line in Medicaid. The first is hospitals. I think hospitals is around $700 million. Medicaid's total budget in South Carolina is about $2 billion, I think, somewhere around that number. So yeah, basically most of my job is working with providers, hospice providers. South Carolina has approximately 95 Medicaid contracted hospice providers. I deal with them with their money, basically making sure that they're getting paid in a timely manner, that they're getting paid for services correctly, that they're not committing fraud. That's a big thing that I have to look at is fraud, and that's mainly comparing numbers. A lot of what I do now is comparing numbers, just kind of looking at a bunch of spreadsheets, that kind of thing, and how trends and numbers move from month to month. Patient enrollment, budgetary numbers, but it is very high level. The other part of what I do is I do write and set policy for the Medicaid hospice benefit. Now we do have a policy precedent that's been in place, but new policy is always coming up. Like the Affordable Care Act a couple years ago, that was a major policy shift. One of the big things was hospice care for adolescents, persons under the age of 21. When you are over 21, you cannot, once you start receiving the Medicaid hospice benefit, you can no longer receive, Medicaid will no longer pay for curative treatments. So when you're on hospice, you're no longer going to be, Medicaid will no longer cover chemotherapy, will no longer cover dialysis treatments, things like that, because the whole idea is that those treatments are no longer necessary. For persons under the age of 21, and this is a change with the Affordable Care Act, they can receive curative treatments and hospice treatments and palliative treatments all at once, and Medicaid will pay for all of those concurrently. So that was kind of a big policy change, and we had to rewrite a lot of our policy books, a lot of our provider instruction manuals, stuff like that.
Well, we are actually proud to say that South Carolina is leading the way in concurrent care, because in North Carolina, they don't have that.
Yeah.
So,
It is actually mandated by the Affordable Care Act, but it is up to the states to implement. That's a reoccurring theme that you see a lot.
No, thank you.
Oh, no.
No, thank you, that's amazing. So we'll have more questions for
Sure.
you, but thank you so much.
My name is Brenda Sanders. I'm the social worker with Lighthouse Hospice, and I've been working with hospice as they mentioned earlier. It was my internship, and they offered me a position, and that's what I've been doing ever since. We also, because of Ms. Kavanaugh, we do get to have interns come through. I said we have 1.5 interns, a part-time and a full-time, and it's a lot of fun working with young people. They're about the age of my children, so it's a lot of fun, a lot to learn. I do go out and do patient visits. We have about 40, we're a very tiny hospice, about 40 people that I see, and I do their monthly psychosocial assessments, admissions. Sometimes I do that, sometimes another coworker will do admissions. We do the comprehensive psychosocial assessments up front, then a monthly psychosocial assessment. Also PRN visits, meaning as needed. I also handle the 13 months of bereavement following the bereaved is the person that's left behind. I follow them, and we find that the majority of families do not want bereavement. They are involved with the faith system already, whether it be their church or some other group. It's only a small group that says, yes, I do want you to follow me for 13 months. And that would consist of mailings, visits, phone calls, so we try to keep in contact with them to see how they're coming along in their grief process. I also am over the volunteer program. Medicare, it is a requirement in hospice that 5% of your employee hours have to be volunteer hours. And you're looking at, you can have volunteers that do direct patient interactions, not necessarily care. Our volunteers don't do hands-on care such as toileting or bathing or anything like that, but they can sit with a patient. They can mow the yard, they can, talk with a family member, they can stay and let someone run errands. So you can have also like administrative volunteers or craft volunteers. That doesn't count towards that 5%. You have to have direct patient or family interaction for that 5% to count. And that is a Medicare requirement. As he was saying, Andrew was saying, we do have Medicaid, Medicare. Hospice is paid for by the Medicare Part A benefit. So it's not something that costs families anything. We don't charge co-pays. You can have a 5% copay. We don't charge co-pays. We pay for the medications that is related to the patient's hospice diagnoses. I explained that if you have something wrong with your heart and something wrong with your kidneys, but your hospice diagnosis is a heart diagnosis, then we'll pay for your heart medicines, but we don't pay for your kidney medicine. We'll pay for comfort meds. Something that I'm seeing within hospice, and I don't know if you have noticed this, we get a lot of referrals from doctors earlier on, and what we're seeing is people say, well, what's the majority of your patients? It's cancer, right? And I say, no, it's Alzheimer's.
it's changed.
So our
So
biggest
much.
diagnosis is Alzheimer's dementia. And what I'm seeing in this with families now, we go into homes, we go into assisted livings, we go into skilled nursing facilities. What I'm seeing with caregivers is that a lot of our caregivers who are at home, or they have a client in assisted living, that they're overwhelmed because they're at home. Let's say it's a wife at home with her husband. They make too much to afford Medicaid, so they can't put him in a nursing home. They don't make enough to pay $16 to $20 some an hour for a sitter. And so you may have a 78-year-old wife with an 80-year-old husband who's pottying in the corner because he doesn't know where he's at, or she's cleaning up poo off the floor, and she's overwhelmed, and she goes to her doctor and she says, I need help. And what does the doctor do? He says, well, let's do a hospice education visit. And so we're seeing more and more and more that physicians are pointing family members towards hospice because they can't get nursing home and they can't afford private duty sitters, and they're trying to get some kind of help into the home. So I feel like there is a gap in the Medicare, Medicaid healthcare system for this generation of clients that do have dementia, this older group, because, you know, unfortunately, as parents get older, so do children. And a lot of times it falls back to grandchildren to try to help provide care. Spouses may not be willing, so there is a bit of a gap in services there that we see quite often in the world of hospice. You can be discharged from hospice, people, and that's something that we have to explain up front. Sometimes people actually get better when they have those extra people coming in, because Medicare will pay for a nurse to come out to the home, they pay for a social worker to come out, they pay for a chaplain, they pay for a nursing assistant. You can get like speech occupational therapies on a case-by-case basis. It's not so much as restoring someone. I had two daughters one time, took their mother home from an assisted living, and they said, can we get a dietary consult, because mother's a diabetic and we don't know how to prepare her meals. And so yes, hospice will take care of a dietary consult for that. We explain to families up front, if your loved one gets better, we can't justify the Medicare while they're on services, they will have to be discharged. People get better. You have all this extra help coming in, they improve. You don't want to use up their hospice benefit, you want to save that for them when they really need it. And then we say, okay, yes, we will come back if there's a change in status, if you need us back, we'll come back, but we've got to do the right thing. If we can't justify someone being on hospice, then they have to come on hospice. That's just the way it is. We don't have a lot of the Medicaid, what we call straight Medicaid in hospice. We have only a few. The majority of our clients are Medicare Part A hospice beneficiaries.
And if I could speak that just for 1 minute, I think a lot of times when you look at the younger Medicaid population, a lot of them are receiving Medicaid waiver services. And so community long-term care, and what happens with that is that they're not able to access hospice. If they choose to have hospice and they qualify, they're eligible, sometimes they have to weigh whether or not I'm going to get a caregiver who comes to my home for 20 hours a week, and I really need that caregiver, versus the hospice team that's going to come and I won't get the same number of hours with an aide. I'll still get that aide, but I won't get that aide who's going to stay in my home. That aide is coming and going. And so that's where some of the rub is in terms of providing that care.
And and that's something too, when we meet with families, if they tell me, we have CLTC, then I'm gonna stop right there and say, okay, you have CLTC, how many hours a week? Maybe 20 hours a week. Yeah, CLTC, community long-term care. That's where a caregiver, PC1, PC2 can come into the home, someone that can help with housekeeping, someone that can help with personal care. They may be getting 20 hours of help a week. Hospice is not gonna get 20 hours of help. That the nurse may come in long enough to do her assessment. The CNA will come in, maybe do the bath. It might be an hour, 2 hours at the most. They're gonna leave and go to the next client. That CLT, that community long-term care worker, may be there 4 hours today. And so I have to say to families, this is about you, this is not about us. What works best for you? And if we're not a good fit for you, then we don't need to be here. Keep what you already have. You don't want your clients to lose something that they're benefiting from just for the sake of saying we have another patient. You can't do that. You've got to respect those patients and families and make sure that they're getting what it is that they need. It's all about them. We tell them all the time, you're still driving the bus. We're here to provide a service. If we're not doing our job, then kick us to the curb. That's a lot of hospices in South Carolina. You know, but you've got to do right by your clients. That's the bottom line. You have to do right by your patients. You have to make sure that those families are getting what it is that they need. This is their end of life journey.
Thank you. Thank you. I want to introduce, we have another person who's kind enough to come again from Nicole Kavanaugh. This is Kathy Jeter. And we don't have time for you to do a full 10 minutes, but can you give like a, no, but I want you to talk about, so that we're going to have questions. So talk about what you do so people can ask you questions afterwards. So, thanks.
And I apologize for being late.
No,
But let me tell you, if you're in the field of social work or anything like that, you're going to learn that your schedule is never your schedule. So what you think you're going to do doesn't always pan out. You know, you have a family that calls you in a crisis or a physician that needs to talk to you. So I apologize for walking in late because that is not my favorite thing to do. My name is Kathy Jeter. I am social worker and volunteer coordinator at Regency Hospice. I have been doing hospice on and off, starting from when I was 18. I started volunteering for hospice when I was in college. I had a death and dying professor, and he was a huge hospice advocate, and I was hooked. And that's really the whole reason I ended up coming here to USC, getting my master's really long time ago. And I've just kind of done it on and off. I've had a period of time that I've been at home with my children. When my youngest was in kindergarten, up came my position. So here I am again. But really just kind of going over everything that I was hearing being said. The thing that I want to emphasize the most about hospice care that I think is so important for the community to understand, because I think it is a terribly underutilized program. And, hospice does, like she was mentioning, hospice is going to pay for your medications related to that terminal diagnosis. They're going to pay for your supplies. These things can be extremely costly on a family. And so not only that, then you have your nurse coming in regularly, your social worker coming in regularly, chaplain, volunteers if the family's up for that. So really those hospice patients are not being treated as just individuals. We treat the whole family system. And that is another thing that I think is very important to realize when you're in the field of, any kind of social work or anything where potentially this is a career you can enter. You're treating it all, and you're treating every single person that's a part of that dying experience. And with saying that, lots of conversations and lots of education on end of life. I heard what you mentioned earlier, that this is not an easy thing. I had someone say to me the other day, when my doctor told me that my diagnosis was 10 months or less, I don't know how to die. Those were his exact words. Well, you're right. You don't. None of us really do until we're in that position. So there's definitely a lot of counseling sometimes involved with certain patients or their families. But beyond that, there's way more than end of life things that you encounter with hospice. I have arranged for a lot of extermination because I have been at homes where there are roaches crawling. I don't sit down. Bed bugs, everything. So you are entering someone's home environment, whether that is assisted living or skilled care or their home. And those homes vary greatly because everybody has that hospice benefit under their Medicare and Medicaid. So you have no idea what you may encounter. And along those lines, they may have someone living in a mobile home behind their home and their grandchild's cooking meth. I'm telling you, you enter it all, I think, as a social worker in hospice. Substance abuse issues, domestic violence issues. Really, so end of life is up front and foremost. But you are the social worker, and you're there. I've had one patient that I was regularly at Harvest Hope picking up his food, because if I didn't do it, there was no food in that home. So, I think it's very advantageous because you have all these great opportunities to do just a gamut of things.
Can I invite you to come up here for questions now? Thanks. Here's a chair.
I feel so bad for walking in late.
No, we're just glad you're here. You're working. So anyway, so you see a very gamut of, experiences. It's open to you all. I'm sure y'all have a lot of. Yeah.
I have a question. You were big on numbers, and you said one of under the age of 21 in your that facility. How many? About, is it a lot or?
Well, in the state of South Carolina, I would say it's actually not a lot. I would put it.
Children.
Yeah, pediatric hospice. But I would say in the state of South Carolina, it's of the 3,500 Medicaid-only hospice patients, probably less than 100 of them are adolescents.
Thank you, thank you.
Is this the field where it would be good to, where it would be okay to have your bachelor's degree, or is it one that you would strongly recommend get your MSW?
Strongly, you have to have your master's if you're gonna do hospice.
Okay.
It's because of the regulations that govern hospice require a master's level social worker. If a program hires
You
a,
require that, that's what I want to know.
it is required for the licensing regulations that govern hospice in South Carolina. The federal regulations will allow for a bachelor's, but they will look at what is the most stringent regulation for the state. And if your state requires a master's, regardless of what the feds say, they're gonna, the surveyors, when they come in to inspect, they're gonna go based on the state regs. Now, there are some agencies who can hire an LBSW, which is a licensed bachelor social worker, but they have to be supervised by a master's prepared social worker. So you might as well, if you're gonna be doing the work, you might as well go ahead and get the master's so you can get the pay.
Good, absolutely.
I was gonna say, and I can speak to that because I worked for hospice in North Carolina for 10 years with my BSW and just moved here and did some research and found out that if I want to continue hospice, working in hospice, then I'm gonna have to get my master's, so that's why I'm here.
I worked with my LBSW for several years. I just got my master's in 2014. Okay. So from 2006 to 2014, I was an LBSW. I went back and got the master's. So you can do it, but someone always has to sign off when you're getting
Yes.
that.
Both sides,
So,
everything
much more.
gets done. Yeah, more autonomy
Yeah.
if you're, you
Yes.
have master's prepared.
I just had more of a comment than a question. So I did, for my undergrad, I did an internship with the Godfrey Hospice in Aging County. And the bereavement coordinator made a comment just speaking about how emotional ride it can be working with hospice. And she was saying, you know, it's an honor to be there when a baby's born, to be at the beginning of someone's life, but it's also even more of an honor to be there toward the end of his life.
That's right.
It's a
And that was
beautiful
just something that
time.
kind of like helped me, because I didn't know what I was getting into, and then I found out that I do love, like I love working with hospice for the amount of time I did.
It's a very intimate experience. I mean, it really is. And I think, you know, when you're working with hospice, you have to truly realize it's a privilege to be there. You know, for families to allow you to be there, like you said, I mean, it can be a beautiful moment. I mean, you can see families holding hands and singing hymns, and sometimes you can see families arguing. So, but it's a neat experience.
You know, we are called to be alongside that family. It's that patient's journey. There are a lot of cultural things that impact what you do. And I like to always bring that up because every family doesn't respond to grief and loss and death and dying the same way. And so when you enter someone's home, that is their home regardless of what it looks like. You will have homes where you get on the porch and you think you're going to fall in. But then you'll also go in homes where it looks like a beautiful mansion. So, but it's their home, and their family dynamics is what they've lived with all their life. So there are all those cultural pieces. So the things that you're learning now, how to deal with spiritual diversity, cultural diversity, all of that's going to help you as you deal with families and what they're dealing with. The majority of folks that we serve in hospice are usually those that are over 65. So 85 to 90% of the care we provide are to seniors. And we do have some hospices that do pediatric care, but mostly those patients, there is a lot of palliative care that goes on for pediatric patients in our state. So.
I'm going to just share a personal experience with hospice care that we had for my father who had dementia. And so it's not, the important thing about hospice care for an older person is, I think you guys have talked about this, Andrew, you certainly did, about how stressful it is and how, is that it isn't just about the person who's dying and you all, everybody's dying, it is the family. So I had a brother who had unresolved issues with my father. Well, let me tell you, bringing him into the decision-making process that my mother wanted and my sister and I wanted for my father, which was not to have a tube feeding, was very complicated. So it's a specialization of gerontology, but you have to learn how to work with all members of the family. And it's really, so I mean, it's really And I agree with you, it's a gift. It's like we bring people into the world, that's an intimate, and we take people up, we help them leave, and this is equally intimate. So it's truly, but Andrew, I totally get what you were saying, and I appreciate it. It's hard, you really have to be, you have to be a certain kind of person. Not everybody can go do this.
Just when I was working down in Conway, one of our patients was a indigent patient, and hospices do take on indigent patients. I think our hospice paid for his hotel room, basically all his care, just out of pocket, charity. Medicaid did cover some things. But he was living in a hotel, so the hospice paid for that. He was homeless. He had been homeless for most of his life, and he was planning on dying homeless. That's what he wanted to do. He had family. He didn't have any desire to get in contact with them. This is how he wanted to die. So part of being in hospice is also respecting the wishes of the patients. You can never, you have your own ideas about how things should be, obviously. It's never about that. It's always about what the patient's wishes are, how you can help them fulfill those wishes. So it ended up being myself and the nurse were the only people there in the room as he passed away. And that's, something that you do think about for a long time. And, hospice is a job where you're going to have situations like that. So not to scare anybody away, but it is it is something you do have to think about.
And I think it's really, I'm sorry, I was just gonna say, I think it's very important to realize you really work as a team.
Yes.
You rely heavily
Yes.
on your coworkers, and, sometimes you're out there and you're fulfilling more of a chaplain role, sometimes the nurse is out there and handling social work stuff, but you need that when you go through these experiences, you need to be able to rely on your coworkers to kind of decompress. And,
The team comes together every 15 days. So when they're on hospice, the team comes together to look at that customized plan of care, and that's where, you're talking about what's going on in the home, and each person is sort of bringing their piece in, and you talk about what else is needed. So there is a lot of camaraderie that is there with the team.
Thank you.
I just had a question. Are the majority of jobs in the gerontology field, would you say that they're in hospice or assisted living or some other area? And when you're working with
No, all across the board.
and when you're working with people in hospice or elders with dementia, do you find that you're working more as social workers with members of the family or with the elder?
A lot of times more with the family.
Yes, I would, from my own experience.
Yeah.
It depends on where they are in the process. If they're progressed, yeah.
And I want to throw out to you, there are a couple of other, when you talk about gerontology, and Alzheimer's in our state is huge. There are over 80,000 people living with Alzheimer's, some sort of Alzheimer's dementia in South Carolina. So if you were a social worker or working with the Office on Aging and working in resource support, as a social worker, you would be touching caregivers and respite and all those things that are resources that we have out there for caregivers. AARP also works with older folks, and I know that they always have social work interns working on projects and policy things, and so you can do a variety of areas, not just in end-of-life care.
Thank you so much. I just want to make sure I get y'all's evaluations. This was so terrific. I can't tell you how much I appreciate it. I just want to let y'all know we have 2 more sessions. 9:20 is going to be case management. 9:27 is going to be continuing care in retirement communities. And now we can have some more questions, but I just wanted to get y'all to do that before we had to get out of here. Because we have how many more minutes, Rita, before we have to leave? We have 3 minutes. So let's have more questions for our panel. Thank you. Thank you so
People
much.
came in from, talking about in-care home agency. So you work, hospice works with, different in-care home agencies, some people will come out,
It's different from
or
hospice.
different.
Okay. It's something that's temporary. Maybe like they're coming out of the hospital or they've had rehab and they need a little extra help at home. Home care will be there for a while, but then they'll leave.
Okay.
Now, your social worker might do some coordination for respite care. That might involve them having to call an assisted living to see if there's a respite bed, or call, not an assisted living, but a nursing home, skilled facility. Or if they need to have folks come into the home. So there's a lot of coordination that you could do as a social worker and working with different agencies in the area.
Sarah, you have a question before we have to leave?
If could you tell us about a couple jobs and maybe how much those people make?
Sure. I would say probably as a starting MSW level social worker with a hospice provider, probably $45,000 in that range. With the state government, relatively similar. Maybe, state government comes along with its own benefits and job security and things like that. But I would say roughly 40 to 45 for a starting position.
Thank you.
Yeah, and just one of the things that I want to remind you all is from the panel, you can see how important it is to remind families and patients that they're not alone. I don't know, and the skills you get in social work are applicable. You've got someone who's advocating to make sure that the money's not being misspent. You've got someone advocating to make sure that the resources that are allotted to the agencies get to the patients appropriately and in a timely manner. So it's not all death dying all the time. It is the management of letting people know that they're never alone during any of this process. And you matter, and I want to thank you because you guys did a great job.
Yeah, no, great.